Hello everyone, this is Tyler again, and for the month of June, we're going to be going over prolonged QT syndrome. This is more geared for advanced EMTs and paramedics, but EMT basics are more than welcome to do this training. There just might be a little gap in knowledge that might make some parts of this a little harder to understand. But we're going to get right into it. So, what is the QT interval? The QT interval is measured from the start of the Q wave to the end of the T wave, and this is going to indicate the beginning of ventricular depolarization and then the end of repolarization. So, it's going to be ventricles contracting till when the ventricles are basically ready to go and fire again. These values differ between men and women. It's not a significant jump from what's prolonged for a man and a woman, but there is a different value. We'll go over that later on in the presentation, though. One thing to note about the QT interval is that it is dependent on how fast the heart rate is going. It's actually an inverse relationship. So if the heart rate is going faster, your QT interval will be shorter. If your heart rate is going slower, your QT interval is going to be longer. So if you think about trying to set like a normal value for people of what's prolonged and what's not, but you have this number that's dependent on how fast or slow the heart rate's going, we need to do something else to get basically a standardized number. There's an equation that is out there that you can use to get your corrected QT interval. However, the Life Pack denotes a QTC, which does all the math for you, and it's very accurate, so you can just use that. Cardiologists, electrophysiologists in the hospital, they might redo it, especially if they're doing like diagnostic testing. However, for us, we can use that QTC that is on the 12-week printouts. So if you forget how long a normal QT interval is, or you're just trying to eyeball and see, oh, is this a little longer than normal? A really easy way to look is see between the RR intervals, split it right in between. If your T wave is starting at that halfway point, you probably have a prolonged QT. It's not an exact science, but it's just something you can kind of look at quickly to see that if this T wave over here is starting at this line or anywhere further, your QT interval is most likely prolonged. So we're going to talk a little bit about refractory periods. So remember that sodium, calcium, potassium are the major players for depolarization and repolarization, where sodium and calcium drive depolarization and potassium drives repolarization. But for all this to start, there needs to be a stimulus that overcomes a threshold to start moving these ions around to make all of these lines happen. So, an absolute refractory period means basically you have your stimulus, it met the threshold, and you're beginning depolarization. You will not be able to start another depolarization no matter how much stimulus you have between the beginning of the Q wave to the first half of that T wave. So, no matter how much stimulation occurs during this period of time, there will not be another depolarization. The relative refractory period takes that the threshold that you needed to do one depolarization and increases it. So if a stimulus is going to exceed that increased threshold, it can depolarize again early. And that's where we see these dangerous arrhythmias come from this. So basically, you'd have an extra beat come in very, very early, and it will overstimulate the ventricles. And we'll kind of go into later on how this is very dangerous and how it leads into a cardiac arrhythmia. So, to talk about these refractory periods and how things can go a little bit chaotic, we want to remember that in a cell where we're repolarizing, our sodium and our calcium are kind of just leaking or not moving at all. And our potassium is is leaking out. So sodium, calcium might be coming in a little bit, but it's not like that big rush when we initially depolarize. So this potassium is resetting us back to that minus 70 where the cell memory wants to be, so it can get ready to fire again. In prolonged QT syndrome, whether it's through a genetic mutation, medication, or some sort of hereditary disease, either your potassium channel does not function as properly, or your sodium or calcium channels gain function. So you either have a loss of function with your potassium or a gain of function with your sodium and calcium. And what this does is it allows that threshold to be lowered, and a stimulus to come in early to throw another beat, essentially. So this is going to be in that relative refractory period. Either you just don't have enough potassium or you have too much sodium or calcium, and that allows for extra beats to happen easier. You just become more susceptible to them. When this does occur, it opens up a reentry pathway in the myocardium, and that's how you develop torsades, and that's why torsades is very commonly seen with people who have a really prolonged QT. And we'll go a little more into that towards the end of this presentation. So range of values. So normal is going to be really between 3.6 to 4.5 for men, 3.7 to 4.6 for women. This long QT is possible. We have a lot of people in these ranges that it's not really considered long QT. But when you get over the 4.5 and the 4.6 in milliseconds, that's when you define it as prolonged. So men, you want to see it below 0.44, 0.45. Women less than 0.46. If you have anybody over 0.500 milliseconds, you're at an increased risk for torsades. And then an abnormally short QT interval, is going to be less than 0.35. But this is the big one to look out for. So if you have someone that has something over 0.5 for that QT interval, you might want to be a little more suspicious, especially if they're symptomatic, that they could go into torsades. And again, just want to remind us that the QTC on those 12 leads is where we're going to see the corrected value. So causes and risk factors. So we have two ways, or they're categorized at two ways to develop prolonged QT syndrome. It's either congenital, you're born with it, or you acquire it. So congenital conditions are mutations that we see within the sodium, potassium, and calcium channels. And like we talked about already in the earlier slides, how the gain of function with a sodium or calcium channel or a loss of function with a potassium channel can cause a lot of chaos in the ventricles. I didn't really do a lot of research on these two syndromes, but Romano-Ward syndrome is a mutation that is inherited from one parent, or it's, I don't even try to go into the pronunciation of this, but this is, you would inherit from both parents. It would cause prolonged QT. There are ways to acquire prolonged QT. So there's some antibiotics and heart medications that will cause it. We see it in hypothermia, electrolyte imbalances, specifically with calcium, magnesium, and potassium. That's why, 1 to 2 milligram push of magnesium is going to be indicated for someone with torsades. Hypothyroidism, and the one medication I left off the slide, which is a little silly because it's one thing that's driven to us at school, Zofran, the one that is most applicable for this, right? So if someone has a prolonged QT syndrome, we don't really want to be given Zofran. Don't need to memorize these; they're just more of an awareness. So yeah, there's a lot of interesting stuff there. So symptoms, sudden fainting spells or seizure disorders. And to specify this is going to be during a time of excitement or fear, stress. So if someone is like getting their heart rate increased for some reason, this is when you'd see sudden fainting spells or a seizure. So those are specifically with excitement, startled, stress, anger. Feeling palpitations, that is another symptom, or having palpitations rather. Dizziness and a family history. Um, the family history is more of a risk factor of having it. So if you have family history of prolonged QT or early sudden cardiac arrest, we're going to be suspicious of you might have a prolonged QT syndrome. Um, but yep, dizziness, palpitations, and then just remember that during excitement or startled, sudden fainting spells, and seizure disorders, which is kind of what we saw in our case study. So, criteria. This is pulled right out of an article from the NIH. There's a lot of findings that are going to contribute to an actual diagnosis. I forget what you have to hit. I want to say it's 2.5 to get a confirmed diagnosis of long QT. So, but that would be specified in that article. Do not quote me on that. I should have had that one written down. But there's a whole bunch of points you can earn from different things. So, your QT interval, corrected QT interval, whether it's in certain lengths, will contribute to points. If you have torsades, you get 2 points because we see torsades quite frequently with this. There's some weird T-wave morphologies that we're going to go over. T-wave alternans and notched T-waves in 3 leads, and then a low heart rate. This is all things that we can see on EKGs that would make you highly suspicious for long QT syndrome. Clinical history, you're looking for syncope. Remember, we just talked about having this present with stress. So they get an extra point. If you have syncope without stress, you get 1, but with stress, it's 2 because you more likely are to see someone with long QT have those syncopal episodes in a time of stress or excitement. Family history, members who do have long QT syndrome, that is a point. And then if you have an unexplained sudden cardiac death at the age of less than 30 in your immediate family, you get half a point. We'll have some statistics that show how prolonged QT syndrome is actually a diagnosis in a lot of people who have sudden cardiac arrest at a very young age. So T-wave alternans is basically the T-waves are alternating. So you have it upright here, inversed, upright. You can see it in this 2-lead too. So inversed, upright, inversed, upright. So basically the T-wave is just alternating directions. Notched T-waves has this kind of like biphasic look to it. Just to go T-wave alternans, you're going to see this usually in V1 through V6. Notched T-waves, V4 through V6 is where you're usually going to see it. But yeah, it's just a little extra bump in your T-wave. You need to see this in 3 leads, according to the criteria, for it to be significant. But if you see this on a 12 lead, it's just something to look out for. So you don't see this really globally. You can see it kind of here in 2, definitely in V4, but those are just 2 different morphologies. So what's so dangerous about prolonged QT syndrome? We've kind of set the stage of what it is and the criteria for it to be long. So why do we care so much? We heard about it so much in school when talking about giving ondansetron, and some people do live with it every day asymptomatically. But 1 in 10 people do not know they have a prolonged QT until they have a sudden cardiac arrest. Unfortunately, a lot of times this does end up in sudden cardiac death. But people who do get ROSC and walk out of the hospital afterwards, they actually find out that it was prolonged QT that caused it. So it's pretty crazy that people who have this prolonged QT diagnosis, 10% of them had to have a cardiac arrest to be diagnosed with it. symptomatic patients who are not untreated, who are untreated, have a 21% mortality rate from the in 1 year from their first syncopal episode. So, someone with prolonged QT syndrome that has had a syncopal episode that is symptomatic consistently, 21% have died within a year of that first syncopal episode. So it's important that people who have these sudden seizures, syncopal episodes, things like that, be investigated. Because there's a few treatments that we'll go over that people can live a long, healthy life just with some changes. So, if you think back to early in our presentation, how we talked about the relative refractory period being a chance where another stimulus can come in and throw another beat, another depolarization, and how prolonged QT through the channels, either gaining function or losing function, make you more susceptible to have these extra beats in the relative refractory period. This all leads to RMT phenomenon. So there's a lot of causes to this, but prolonged QT is one of the main ones, and it's the one we're going to focus on, obviously, for this presentation. So RMT is when you have that early depolarization in the relative refractory period, and a PVC occurs on the second half of that T wave. In the myocardium, the stimulus basically circles, and that's why you get that crazy switching of points, Torsades de points. So this can lead to cardiac arrest if untreated. You usually do not self-convert out of torsades, and it occurs in the relative refractory period. Electrolyte imbalances or myocardial ischemia are two other causes, but again, just hammering home like the mag sulfate for if you do see torsades, might be able to reverse that. But this doesn't show a prolonged QT interval, but this does show how you have your regular beat, and then halfway through your T, you have this PVC, and it's going to send you in a polymorphic VTAC. So that's kind of how we discussed how this happens with ion movement, and now we're seeing it on the 12 lead. So relative refractory period, early depolarization causes this PVC on the T wave, goes into torsades. Treatment. So we have three treatments that you commonly see for people with prolonged QT syndrome. First is a beta blocker, and the most common one is propranolol that is prescribed. Left cardiac sympathetic denervation, or LCSD, is another treatment, and basically this is just going to take away the sympathetic response, so you aren't able to have like that pathophysiological response to episodes of excitement or being startled. You're not going to increase your heart rate, have that stress, and make it more likely for you to go into torsades, essentially. You're not curing prolonged QT syndrome by getting that surgery, the denervation, but you're making it less likely that this is going to happen. People who do get the surgery see a 91% decrease in cardiac events in the first 8 years that they have it done. So it does work, for sure. Ultimately, an ICD is going to work best for these patients. And you don't usually see an ICD unless there is a specific known mutation that is very dangerous or you've already had a cardiac arrest. But basically, it's just going to shock you right when you go into torsades. 28% of these patients who get an ICD do feel another shock after they get it implanted. So it's definitely a life-saving intervention. But that is the presentation. Here's the quiz link. Remember to fill out the roster and evaluation, and please reach out if you have any questions. Thank you very much for watching.